Yes, Assalamu alaikum everyone. I am Dan Almazroua. I'm a third-year medical student, and today, inshallah, we will be discussing spinal cord and tracts. Okay. So first, we're going to start with some basic anatomy about the vertebral column and the spinal cord, and then we're going to move to a more detailed explanation. So starting with the vertebral column, the vertebral column is made of 33 vertebrae. So we have the cervical vertebra, 7 of them, and then we have 12 thoracic vertebrae. Then we have 5 lumbar, 5 sacral, and 4 coccygeal vertebrae that are fused together to form the coccyx. Okay. Now the spinal cord lies within this vertebral column. However, it lies within the vertebral column. However, it doesn't go all the way until the end of the vertebral column, but it rather ends at the level of L1 to L2 in adults and L2 to L3 in infants. Okay. And this is important for purposes that we're going to discuss later on in the lecture, inshallah. But just memorize these numbers. They're frequently asked and know at which level does the spinal cord end. And you should know at the adults, it is L1 to L2, and it's infants, it is L2 to L3. Okay, I just need my pointer. 1 second. Okay. So when it comes to the vertebrae, we're going to discuss them briefly. We have the cervical vertebra. So we have the vertebral body here, and then we have the vertebral foramen. The vertebral foramen is where the spinal cord passes through. So we just said that the spinal cord is found within the vertebral column, and it's found in this vertebral foramen. One very important feature in the cervical vertebra is the presence of a transverse foramen in this transverse process. If you look at the other vertebrae, they all have transverse process. However, none of them has this transverse foramen except for the cervical vertebra. And this is relative to the blood supply of the spinal cord when we reach to that point. And then we have the thoracic vertebrae, and a distinguishing feature would be the presence of the facets at the transverse process that allows the articulation with the reps. And then the lumbar vertebrae, it has a very big vertebral body, and this is how you can differentiate it. We're just passing through these briefly because this is not the focus of the lecture. Okay, so when it comes to the vertebral column, between each vertebra, there is a structure that is known as the intervertebral disc. This intervertebral disc is important for shock absorption. So whenever we have any trauma, whether it's a minor trauma or major trauma to the vertebral column, this intervertebral disc is important for shock absorption. So it doesn't allow whatever trauma to kind of cause damage to the vertebral body itself, or it causes any fracture in the bones. It rather absorbs the shock, and this maintains the vertebral column in a healthy state. Now, the anatomy of this intervertebral disc is that in the center, we have a structure that is known as nucleus, a nucleus pulposus, and at the periphery, we have the annulus fibrosus. This annulus fibrosus, as the person ages, it starts to become thinner and weaker. And as it becomes thinner and weaker, this will lead to a condition that is known as disc prolapse. If you look at the picture here, in disc prolapse, what happens is because the annulus fibrosus becomes so thin that it becomes so easily broken, the nucleus bulbosus kind of protrudes and it pushes the annulus fibrosus, breaking it, and it starts compressing in either the spinal nerve or the spinal cord itself. And this becomes problematic because it causes very severe pain, and it's a very common condition in the elderly. So what is the cause? It's mostly in the elderly due to thinning and weakening of the annulus fibrosus, and the nucleus fibrosus protrudes and start compressing on the spinal nerves. Okay. Now we're going to talk about the spinal cord in general. Now the spinal cord, we said the vertebral column has 33 vertebrae, but the spinal cord has only 31 pairs of spinal segments. Now each segment of the spinal cord gives a pair of spinal nerves. One nerve exits from the right side and another nerve exits from the left side. Now, if you look at the spinal cord, there are two enlargements, one at the cervical, and it's not very obvious in this picture. There's another enlargement similar to this one at the lumbosacral region. And this enlargement is important for the formation of plexuses. So the cervical plexus, brachial plexus, or the lumbosacral plexus, which are important for innervation of the limbs. So the upper limbs in case of cervical and brachial plexus, and the lower limbs in case of the lumbosacral plexus. Again, emphasizing on the points that the spinal cord ends at L1 to L2 in adults. And if you look at the spinal cord, as it's ending, it's going to form a cord-like structure. A cone-like structure. And this cone-like structure is referred to as the conus medullaris. And this is just at the level of L1 to L2 where the spinal cord is ending. Now you might think that we have like the areas of L3, L4, L5, the sacral region as well. All of these areas, they need innervation. But where do these nerves come from? Now these nerves, even though the spinal cord is terminating at L1 to L2, they exit from the spinal cord and they go descending downwards. So the spinal cord ends here, and then the nerves descend downward. As they're descending downwards, they're going to form a structure that is called cauda equina. Cauda equina is the Latin word for horsetail. So if you look here, this is the conus medullaris. This is around L1 to L2 level. After that, the spinal cord has terminated. Now the nerves are going down, descending to reach their corresponding vertebral level. Vertebral level. And as they're descending, they're going to form the structure that is called cauda equina. Now, another important thing to know is that the spinal cord, just like the brain, is also covered by meninges. So we have the dura mater, then the arachnoid mater, then we have the pia mater. So when it comes to the cerebrospinal fluid, it usually is found between the arachnoid and the pia mater, an area that is called the subarachnoid space. And this is important because the cerebrospinal fluid can serve as an important sample for lots of disease, diagnosis of diseases, and many other things. So it's commonly taken. And this is when we relate the ending of the spinal cord at L1 to L2 and the lumbar puncture, which I'm going to explain later, okay? Okay, so now when it comes to the arachnoid and the dura mater, they extend all the way up until S2. And even though the spinal cord has terminated, the dura and the arachnoid mater go down. And this is good because this allows the cerebrospinal fluid to be present in levels even below the spinal cord. And then we have the pia mater extends even further until the tip of the coccyx and a very thin structure here, which is called the phylum terminal. So just to make it clear, in the spinal cord, we have two enlargements. We have the cervical enlargement and we have the lumbosacral enlargement. And then it's covered by meninges, just like the brain. At the subarachnoid space, we have the cerebrospinal fluid. And also, I want you to remember that the subarachnoid space between arachnoid and pia mater, there are many questions that ask you, where is the subarachnoid space? And it's often very confusing, even though it's very simple. Some people would think arachnoid and dura, but it's pia mater. And that's mainly it, okay? Now, when we're talking about the lumbar puncture, which is the process by which they collect the sample of cerebrospinal fluid, they usually insert a needle at the subarachnoid space where the cerebrospinal fluid is present. But what's important here is that inserting this needle can possibly damage the spinal cord, which is not what we want. We want to avoid entering the spinal cord or penetrating it by the needle. So the safest way to insert the needle is to penetrate the needle at a level that is below the spinal cord. Sorry, but I just want to see your chats. Okay. Yeah. Okay, so we insert it at a level below the needle. And can someone tell me where did we say that the spinal cord ends in adults?
L1 to L2.
Yes, L1 to L2, exactly. So we said it ends at L1 to L2. So this is why when we insert a needle to collect the cerebrospinal fluid, we try to go at the level that is below L1 to L2. So commonly in adults, we go to the level L3 to L4. And in case of infants, it ends at a level below. It ends at the level L2 to L3. So we try to go to level L4 to L5, which is even lower, to avoid injury to the spinal cord. Okay, this is a question that you'll definitely get whether in your midterm or your final. It's commonly asked. I've seen it in almost every past question. They can ask you in two ways. Either they ask you, at which level does the spinal cord ends, or at which level is it the best level to insert the needle. So know them very well. They're very easy, but they can be very confusing when you're memorizing lots of information. Okay. Okay. So now we're going to discuss another finding in the anatomy of the spinal cord, which is this ligamentum denticulatum. Can you guys see my pointer? Okay, never mind. Yeah, now you're supposed to see it. Okay, so this is the ligamentum denticulatum, which is the extension of the pia mater. Now, the importance of this ligamentum denticulatum is that it stabilizes the spinal cord, and it does so by taking the pia mater and then taking the subarachnoid mater, the arachnoid mater as well, attaching it to the dura. So the pia, arachnoid, and the dura mater would all be attached together, and this is the spinal cord. Because if you think about it, the spinal cord is not really attached to anything. So, or you get lost. So, is the spinal nerves that are exiting from each segment of the spine. So they go through, as you see these. Oh, no, it's not normal to see the presenter view. Okay, thank you for telling me. I'll just. أصلا I didn't. Okay, خلاص. This is good. I removed the presenter view. أصلا I don't need it. Thank you for telling me. Okay. Anyway, so yeah, where were we? Okay, so the ligamentum denticulata is going to take the pia mater, attach it to the arachnoid mater, and then the dura mater, and this stabilizes the spinal cord. Okay, this is mainly it. So now we have a question that was related to the lumbar puncture. Can you please, guys, tell me what the answer is? Take your time answering it. It's very simple. Okay, so everyone got it right. It is C. And this is how the questions can be asked, or it can be switched. And they tell you, and they're inserting a needle for a lumbar puncture, and what's the best level to insert the needle, and the answer will be L3 to L4 or L4 to L5, okay? Tamam. Does anyone have a question about the things that I've explained earlier? It was just kind of an introduction, but if there's anything that's unclear, I can go and re-explain it. Okay, perfect. Okay, so now we're going to talk about the vertebral level and the spinal segments. Honestly, I remember when I was a second year and studying the spinal cord, I really liked the spinal cord lecture, except this part. No, I didn't like, memorizing the spinal nerves and their corresponding segments. But I now see it as a very simple thing. And this mainly because I kind of understood why the nerves are oriented in this way. So as I've already mentioned, we have 33 vertebral, and we have 31 spinal nerves. So each nerve exits at a specific level. When it comes to the cervical nerves, however, and the cervical spinal nerves, there are 8 of them, even though the cervical vertebrae are 7. So why is that? Honestly, you don't need to know this information. I'm just going to say it so that it makes more sense to you. When you study the nerves, just know it and you don't need to memorize it. Is that at the embryology, the occipital bone was basically fused with the first vertebra, and they now refer to them as the occipital bone. Occipital bone is the bone at the base of your skull. So we originally had 8 cervical vertebrae, but then after one fused with the occipital bone, we now have only 7. And this is why we have 8 cervical spinal nerves. And this explains to you why the cervical spinal nerves are the only nerves that exit above their corresponding vertebral level, whereas the rest of the nerves, they tend to exit below. So let's start with the cervical vertebra. I just mentioned it exits above. So in order for you to remember at which segment corresponds with which nerve, C1 would exit above the C1 vertebra, C1 nerve. And then C2 nerve would exit above above the segment that is below. So let me just draw it so that it makes more sense. I feel like just saying it would be harder. Okay. So this is your cervical vertebra. We have 7 of them. And then you have the cervical nerves. Let me just change the color. Okay. So the first cervical nerve exits above the first cervical vertebra. And then the second cervical nerve would exit above the second cervical vertebra, and so on. And this is how you reach the conclusion. Each nerve is above the cervical vertebra. Now, when it comes, let's assume that this is C7. When it comes to C7, and then we have after that the first thoracic vertebra, this is where C8 exits. So C8 nerve would exit above the thoracic vertebra and under C7. And this is why after that, all of the thoracic nerves would exit below their corresponding thoracic vertebra. But the thoracic nerves are not really as organized as the cervical nerves. They tend to go even 2 levels below or 3 levels below, or they ascend. So they kind of move. They're not exactly as well oriented as the cervical nerves. So this is why all you can do, honestly, is memorize it. All the thoracic vertebra, up until the level of 7, you need to add 2 to it in order for you to know what's the spinal segment that is exiting would be T5. Or for example, if it's T2, the nerve that's exiting would be T4. However, in the lower thoracic vertebra from 7 to 9, you're going to add 3. So at T7, you're going to have T10 exiting, and so on. This is all the thoracic nerves that are exiting at the thoracic vertebra. But then when you reach T10 خلاص, you no longer have thoracic nerves. You start having L1 to L2. And then T11, you'd have L3 to L4. And then at the T12, you're going to have L5. And then at the first lumbar vertebra, you're going to have all the sacral and the coccygeal segments. And this should make sense to you because at L1, the spinal cord ends. So let's say this is the spinal cord. Okay. And as it ends at L1, we're going to have the conus medullaris. Just imagine that this is the conus medullaris. After the conus medullaris, at around L1 to L2, we're going to have the cauda equina. And the cauda equina is basically the sacral and the coccygeal nerves. So it makes sense that all the sacral and coccygeal nerves exit at the first lumbar vertebrae. The rest of them, you unfortunately just have to memorize them. I think the cervical would be easy to add one because you know one exits above. The thoracic, just know early on it's 2, 3, but then these are just pure memorization. I wish I can help you, but honestly, this is the best that I can just make sense of it. The rest is just pure memorization because the nerves are not really so organized. Okay. So now, this is just words for what I said. And now let's talk about the anatomy of the spinal cord in more details. If you look at the spinal cord, if you look anteriorly, we have the anterior median fissure, which is this structure here. And posteriorly, we have the posterior median sulcus. Now, can someone tell me what's the gray matter and what's the white matter? That's something you probably already know.
The white matter is the axons and the gray matter is the cell bodies.
Yes, exactly. So the cell bodies inside the central nervous system are referred to as the gray matter, and the white matter are the axons or the myelinated axon. The myelin sheath gives them the white color. Okay. So now, when it comes to the spinal cord, the gray matter is found in the center of the spinal cord, which is this butterfly-shaped structure. And I would advise that you know this thick structure here is the anterior of the spinal cord, because this was an OSPE question for us last year. They were like, which side is the anterior? So just know, whenever you see the gray matter kind of thicker, it's the anterior portion of the spinal cord, okay? Now, the gray matter is, as I said, is in the center, in contrast to the brain, where the gray matter would be on the outside, okay? And the white matter is on the periphery. Now, when it comes to the gray matter, they're divided into anterior gray horn cells and posterior gray horn cells. The anterior gray horn cells would have the motor fibers or the cell bodies of the motor neurons, and the posterior gray horn cells would have the cell bodies of the sensory neurons, okay? Now, anteriorly, when you look at the nerve structure, we have an anterior rootlet and a posterior rootlet. Anteriorly, we're going to have the motor fibers. So the root has pure fibers. So it's either going to be sensory or it's either going to be motor. A root is never mixed. The anterior root is motor and the posterior root is sensory. Now, if you look at the posterior root, there's this structure here, which is called the dorsal root ganglion. It's the ganglion that has the cell bodies of the sensory fibers, of the sensory neurons, sorry. Can someone tell me what type of neurons is found in the dorsal root ganglion?
First order.
Yes, first order neuron. Yes, that's when it comes to the tract, but I meant, is it a regular neuron or a pseudounipolar? Yes, exactly. It's a pseudounipolar neuron. So the pseudounipolar neuron structure would have a peripheral end and a central end. The peripheral end would kind of take the information from our hands or from any peripheral organ, like from the legs, and then the central process would take the information to the spinal cord. This is how the pseudounipolar neurons are oriented. And then after that, one important thing here to know is that the spinal cord is covered by the arachnoid and the dura mater, okay? And why is that important? And it's not only the spinal cord, it's also extending all the way up until the formation of the spinal nerve. I initially assumed only the spinal cord would be covered by the pia, arachnoid, and dura mater, but that's not the case. They will extend all the way until the nerve, and this can be used in diagnostic purposes. They sometimes inject a dye in the subarachnoid space, in the cerebrospinal fluid, and then they take a radiograph. If there is a compression of the spinal nerve, let's say there's a lesion here or a tumor here that is compressing, you will not see the dye going all the way until the nerve. It will stop. It will prevent the dye from moving. So this is one of the way to kind of diagnose if there is a compression of the spinal nerve and injecting a dye and then taking radiographs of it, okay? So that's it for now. Now we're gonna talk about the blood supply to the spinal cord. So we mentioned here, oh no, we didn't actually. Okay, if you look at the spinal cord here, this artery here is the anterior spinal artery, and it supplies the anterior 2/3 of the spinal cord. Now we're gonna talk about the origin of this anterior spinal artery and other arteries that are supplying the spinal cord. Again, this is the spinal cord, and this is the anterior spinal artery that I'm pointing here. Okay. Now, this anterior spinal artery is actually formed by the union of two vertebral arteries. Remember when I said in the cervical vertebra, we had the transverse foramen and the transverse process, which is found here. Now, in each transverse foramen, we have two vertebral arteries that are running, okay? And they're going all the way up. So they originate here from the subclavian arteries. So just imagine it's in your body. You have subclavian arteries, and then in the cervical vertebra, you're going to have the vertebral arteries going all the way up. So they go all the way up, up, up until they reach the base of the brain or the brain stem at the medulla. Now, at the medulla, both vertebral arteries will join together here. Just follow what I'm drawing. These are the vertebral arteries, okay? And they would join together, forming the artery that is called as the anterior spinal artery. This anterior spinal artery is very important in supplying the anterior two-thirds of the spinal cord up until the level of T8, okay? Now, when we reach the level of T8, there are other arteries that are contributing for the supply of the anterior two-thirds of the spinal cord. One very important artery is the intersegmental artery T8. The intersegmental arteries are arteries that are coming between each segment. They're coming directly from the aorta, so they're branches from the aorta. The other arteries do not have that significant contributions, or if there is damage to them, there wouldn't be that significant pathology associated. But when it comes to T8, it has a very significant contribution to the supply of the spinal cord, especially at the level of T8 and below. And this artery is also known as artery of Adam Hewigs. I'm not sure about the pronunciation, but yani, you got the point. It's just this artery. So this is when it comes to the anterior two-thirds of the spinal cord. So at the top, it's the anterior spinal artery, which is formed by the union of two vertebral arteries. And at the level of T8 and below, it's mostly the intersegmental artery at the level of T8 or the artery of Adam Hewigs. Now, when it comes to the posterior one-third of the spinal cord, we're going to have the vertebral arteries again, but not the posterior portion. This is like kind of the spinal cord, but taken from the posterior aspect. These two vertebral arteries that just join together and form the anterior spinal artery in the front would join together from the back. Actually, they don't join. They're going to give two posterior spinal arteries. These two posterior spinal arteries would supply the posterior one-third of the spinal cord. So just to repeat, the anterior two-thirds of the spinal cord is mainly supplied by two arteries. The anterior spinal artery, which is made by the union of two vertebral arteries. And then at the level of T8, it is artery of Adam Hewigs. And then the posterior one-third of the spinal cord is supplied by two posterior spinal arteries that are coming from the vertebral artery, okay? And this is just words of what I said again. And that's it for the blood supply of the spinal cord. This is the most important thing for you to know. Does anyone have a question regarding the blood supply before I move to the next point? Okay, perfect. Okay, so the white matter is divided into three parts. We have, as I said before, there's the anterior median sulcus and the posterior fissure, okay? Now, when it comes to the anterior median sulcus and the anterior rootlet, it's going to form kind of a triangle here. This triangle is referred to as the white column, okay? Anterior white column, sorry. The anterior white column. And then we have the lateral white column, which is found between the anterior rootlet and the posterior rootlet, which is this structure here. And this is the lateral white column. And then the last one would be the posterior white column, which is found between the posterior median sulcus and the posterior rootlet, okay? And this is how it's divided, and this is just to make it easier for us to study the spinal cord and the white matter of the spinal cord, okay? Now, the spinal nerve, I've mentioned this before, that is formed by the union of the dorsal root, which is sensory, and the ventral root, which is motor, and they both join together forming the spinal nerve. So the spinal nerve itself is a mixed nerve. It has both sensory and motor fibers. And then there's also a contribution from the autonomic nervous system, the sympathetic ganglion. So there are also sympathetic fibers in the peripheral nerve. So whenever we have a peripheral nerve, it has three mixed fibers: sensory, motor, and sympathetic. Okay. Okay, so when it comes to the after we form the nerve would then divide into a ventral ramus, and a dorsal ramus. Now, the ventral ramus mainly supplies the anterior and the lateral body wall. And another information to know about the ventral rami is they form the plexuses. So a plexus, whether it's a brachial plexus, cervical plexus, or any type of plexus, it's never formed by the dorsal ramus. It's always formed by the ventral rami. They join together and they form the plexuses. Whereas the dorsal ramus is mainly responsible for supplying the medial and the posterior part or the skin of the back, okay? So this is for the dorsal ring. Now we're going to talk about the different segments of the spinal cord. So the spinal cord, even though it has gray and white matter, the shape or the amount of gray and white matter throughout the spinal cord is not uniform. And it makes so much sense of how they're, subhanAllah, they're divided when you understand the reason. So this is the cervical segment. We have the anterior gray horn cells, and you can see that they're relatively very big. And this is because the cervical segment supplies the limbs. So the upper limbs are supplied by the cervical segment. So you can see the anterior gray horn cells are big. And then you can see the white matter at the cervical segment is huge. You have lots of white matter. And this is because if you think about the spinal cord, there are so many fibers that are ascending to your brain throughout the spinal cord, and all of them must pass through the cervical segment in order for them to reach the brain. So whether it's coming from your lower limbs or coming from your upper limbs, they eventually have to pass through the cervical segment so that they reach the brain. I think the next picture is clear. Yes, okay. So here the black is the white matter and the white is the gray matter. You can see that the white matter at the cervical region is very big, and this is because all the fibers have to ascend and pass through the cervical region. And then at the thoracic segment, you can see that the anterior gray horn cells are relatively very small. This is because at the thoracic region, there's only the thoracic muscles. There's not, there's not no limbs that are being innervated, basically. So the anterior gray horn cells would be very small, or smaller than the cervical segment at least. And then at the lumbar region, you're going to notice that the anterior gray horn cells again become bigger because they're supplying the lower limbs. And then if you look at the sacral region, you're going to see that the white matter is very small. There's not much white matter. And this is because there's only very few ascending fibers coming from the lower limbs that are passing through the sacral region. And then they start adding up as you go higher in the spinal cord. But at the sacral region, there are barely any ascending fibers that are forming the white matter. This is for the distribution. You might get asked about these in OSPI, like which one is the segment of the spinal cord, so try to know them. They make so much sense once you understand the reasoning behind why each one of them is shaped the way it is, okay? Does anyone have a question so far about the segments of the spinal cord or anything I've explained? Or is it clear? Okay. So now we're going to talk about the reflex arc. Honestly, this is a topic that you're going to mainly discuss in physiology, so I'm just going to touch upon it very briefly because a bit of it is related to our lecture. So the reflex arc is made of so many components. The first one would be the receptor. So you'd have a receptor, and after the receptor, you're going to have an afferent neuron. So if you look at this picture here, the afferent neuron would transmit the signals, whatever they are, whether it's a temperature, whether someone is facing any type of pressure, pain. The reflex arc is mainly just a protective mechanism. Whenever you touch something, your body just immediately and very fast and rapidly moves your hands away from the subject that you're touching, okay? So the way it works, we have a receptor that will sense whatever you just touched. Let's just, in this example, it was the fire. So they touched the fire, they felt the heat, okay? So this is going to be sensed by the receptor, and then it's going to be transmitted through the afferent fibers. Now the afferent fibers would enter the spinal cord, and then you're going to have the efferent fibers, which will tell your muscle and contract and move your hands away, okay? And this is an important protective mechanism in our body. Any interruption of the components of the reflex arc, whether it's the afferent or the efferent fibers, it will abolish the reflex arc. This response would not be present. And because it wouldn't be present, the person would suffer from flaccidity, and the muscles would not be contracting very well. The person would have hyporeflexia, meaning it doesn't reflex. Hypo means less, so there won't be enough reflexes. And these are all signs if there is any damage of any of the components of the reflex arc. Now, this reflex arc, although in high school, I personally studied it, that it works on its own, but that's not really the case. There is influence that is coming from the upper motor neuron in this reflex arc. So there is either excitatory or inhibitory effect on this reflex arc. We can discuss different tracts in the motor system. But the main tract is the pyramidal tract. This pyramidal tract is the only one that is excitatory to the reflex arc, and all the other tracts are inhibitory. But the net effect of all the upper motor neurons on this reflex arc would be inhibition. So if you have inhibition on the reflex arc, why is that important? And why would you have inhibition? Because we are continuously having certain stimuli. Now that I'm talking to you and explaining to you, I've touched so many objects, I've received so many stimuli, but I haven't contracted my arms. And this is because of the protective mechanism that we have in our upper motor neurons are inhibiting this reflex arc, and this is important when you inhibit this reflex arc, so you don't have involuntary movements. I don't just contract my muscles when I don't need to contract them. And whenever we perform the reflex arc, this inhibition is kind of removed, okay? Now, what happens is, in certain times, there are lesions of the upper motor neurons, okay? And whenever we have a lesion in the upper motor neuron, the reflex arc would not be inhibited. The inhibition is removed. And this is really bad because the person would now have hyperreflexia. They would have exaggerated reflexes. They will have spasticity. Spasticity is when the muscle becomes so rigid and so tense and it's contracting in a very tense way. This is spastic paralysis that happens in the muscle. So this is an important way to differentiate between the upper motor neuron lesions and lower motor neuron lesions. When it's an upper motor neuron lesion, you're going to see that the tone is increased. And this is because you're not inhibiting the reflex arc. There is spasticity. Clonus is very similar to spasticity, is when the muscle is contracting on its own. And then hyperreflexia. These are all upper motor neuron lesion signs. When it comes to the lower motor neuron signs, you're going to see that the tone becomes very, very weak. The muscles become very flaccid. And there is atrophy of the muscles, their fasciculation. These are all signs of lower motor neuron lesion. This is, again, one of the very high-yield concepts that are very frequently asked. Hatta when I passed over the previous batch questions, they were all asked. Okay. So now this is a question about the cervical vertebrae. Can someone answer? Okay, all of you answered it correctly. The cervical nerve exits above its corresponding vertebra, and we explained why, because the occipital bone was originally a vertebra. And then the fifth thoracic nerve would exit below, because we said anything below the cervical vertebra just exits below its corresponding cervical segment, okay? This is a very easy question. We're starting with very easy ones. But it was in the previous batch questions. Yes, exactly. All of you answered A, and it's true. And this is because the root wouldn't have any mixed fibers. The root is pure, and then the nerve is the one that would have a mixed fibers. Okay. True, it is A. Now we're going to move to the gray matter, which, as you mentioned, it's the collection of neuronal cell body in the CNS. Now we're going to study the gray matter briefly. All of what we're studying now is kind of preparing us for the tracts. So the more we understand it, the easier it gets for us to understand the tracts themselves. So we mentioned before that the gray matter is found in the center of the spinal cord, and it's a butterfly-shaped structure. And this is the butterfly-shaped structure. We'll discuss it in details, okay? So when it comes to the gray matter, it's divided into three groups. We have the anterior group, the lateral group, and the dorsal group. And in my slides, I have color-coded them. When you see purple, it is the posterior one. When you see green, it is the lateral. And when you see red, it is the anterior. Now, we're going to start with the posterior gray horn cells, which is this group, this segment here, okay? I don't like the line, so I'm going to remove it. Okay. So the first one is called substantia gelatinosa. And then there's nucleus proprius and dorsal nucleus. The way you need to think about them is that they're kind of columns that are the spinal cord, and they contain cell bodies, gelatinosa, and it's present throughout the whole length of the spinal cord. So from the cervical segment up until L1 to L2. Oh, let's go to the laser pointer. So I'm just going to repeat what we said. We said the gray matter is found in the center of the spinal cord and it's butterfly-shaped. And to understand them better, we have divided them into posterior group, lateral group, and anterior group. In the posterior group, there are three main kind of columns of cells that are present in the posterior group. The first one is substantia gelatinosa. Now, when it comes to substantia gelatinosa, it's the one that is present throughout the whole length of the spinal cord, okay? So from the cervical segment up until L1 to L2 of the spinal cord, the substantia gelatinosa is present. And the main function of substantia gelatinosa is going to be pain and temperature, and basically crude touch and pressure as well. We're going to explain it further. You're going to understand it more when we discuss the tracts. Just know that the main function of substantia gelatinosa is pain, temperature, and crude touch. Then we have nucleus proprius, which is also present throughout the whole length of the spinal cord, again, from the cervical segment up until L1 to L2, and up until the spinal cord ends, and it's mainly responsible for conscious proprioception, two-touch discrimination, and vibration. Now, let's discuss what does conscious proprioception mean. Proprioception means knowledge of one's position and knowledge of some, if when you sit down and you مثلا lift your thumb up, when you know that your thumb is lifted up, this is you consciously are aware of the position of your thumb, okay? That's what we call conscious proprioception. And this is commonly tested to test for different tracts and even the cerebellum. We're gonna discuss this later. But the way they test it is they ask the person, for example, to close their eyes and then they hold the finger. You're gonna do it in pro, by the way. And then you lift their finger upwards and you ask the person, where did your thumb go? If they say upwards, this means they have a good proprioception, a good awareness of their positions and where they're placed, okay? That's what we refer to as conscious proprioception. Now, two-touch discrimination is something else. It's when you try, it's just not like any touch, it's when you touch very fine structures. For example, if you have two very fine needles and you insert the needles on the hand, while I'm closing my eyes, someone comes and insert two needles in very close proximity to one another, I can tell that these are two different structures that are touching me at this time. When I can differentiate and tell, okay, these are two different structures, that is called two-touch discrimination, because I can discriminate that these are two structures that are touching me or kind of pricking me. It's not one structure. That's the difference between two-touch discrimination and this the regular touch, which we refer to as crude touch. Okay, I think I have a picture, yes, here. Now, the two-touch discrimination is very finely regulated in our hands and our fingers. So if someone like touches you on your finger and they put two needles, you can tell, and okay, these are two needles in my finger. You wouldn't feel them as one structure that is touching you. However, in the back, and if you look at the difference, this is 3 to 8 millimeters. This would be 36 to 75 millimeters. At the back, you wouldn't really tell that these are two different structures. If someone touches you, you just assume, okay, this is one structure that touched me because they are very close to one another. So the body doesn't see it as two different structures. This is just to understand what does two-touch discrimination mean, okay? And then vibration is just for any vibration. Like, for example, if your phone is vibrating in your pockets or you put your hands on the radio while it's playing, this is the time where you sense vibration. And then we have the last column, which is Clark's column, which is this one. Now, Clark's column, in contrast to nucleus proprius and substantia gelatinosa, it is not present throughout the whole length of the spinal cord. It is rather present from C8 to L3 to L4. And it's responsible for unconscious proprioception. Now, what's the difference between conscious and unconscious proprioception? Unconscious proprioception is that when you unconsciously are aware of the position of your limbs. While you're walking, you don't know that your leg is that high from the floor, for example. Or for example, let's say I want to grab this cup, okay? And my brain tells me, no, yalla, grab this cup. I unconsciously know that my hand is this far away from this cup. If there is a problem in my unconscious proprioception and I don't know where my hand is, I would hyperextend, and rather than holding the cup, I would just go further. This is why unconscious proprioception is important. It tells you where your limbs are, where your ligaments are, where your muscles are, or anything that's required for your movement, so you know where you're at before performing the action. If there is any problem in the unconscious proprioception, there will be uncoordinated walking because you wouldn't know where your limbs are, or as I said, you would hyperextend or not reach enough for the object that you're trying to reach, and so on. These are the problems that will arise if there is a problem in the unconscious proprioception, okay? And this is the function of Clark's column or the dorsal column, which is only present from C8 to L3 to L4. It's not present throughout the whole length of the spinal cord. This is for the first group, which is the posterior gray horn cells. Now we're going to move to the lateral gray horn cell. Now, the lateral gray horn cell is only present in the thoracic and the lumbar segments of the spinal cord. And this is because there is only one group that is present there, which is the intermediolateral nucleus. Now, this intermediolateral nucleus has the preganglionic fibers for the sympathetic neurons. And we know the sympathetic, can someone tell me actually where the sympathetic fibers go from? Like where does it extend, the sympathetic nervous system? I'm not sure if you took it actually, but do you remember it? I'm sure we took it in first year. Yes, exactly, T1 to L2. So this is why, if you think about it, it makes so much sense to you. نحن we know that the sympathetic nervous system only extends from L1 to from T1 to L2. So it makes so much sense for the intermediolateral nucleus or the lateral gray horn cells to only be present in the thoracolumbar segments, because this is where the sympathetic fibers are present أصلا. And that's the function of the intermediolateral nucleus. It's very simple. And then we're going to move to the anterior gray horn cells. And the anterior gray horn cells are different from at each segment of the spinal cord. So they're different at the cervical segments, at the thoracic, lumbar, and so on. So when it comes to the cervical segment, we have medial, central, and lateral group. The medial group would be responsible for supplying the neck muscles. The central group is responsible for the formation of the accessory nucleus and the phrenic nucleus. You're going to take these nuclei again in the brainstem lecture, and it's going to make more sense to you. But for now, to make it easier for you while studying the brainstem, the accessory nucleus is responsible for innervating the trapezius and the sternocleidomastoid, and the phrenic nucleus is responsible for innervating your diaphragm. And then we have the lateral group, which is responsible for supplying the upper limb at the cervical segment of the spinal cord. Now we're going to move to the thoracic segment. We only have medial group, and it supplies the trunk muscle, because there isn't much in the thoracic segment. It's only the trunk muscles that are there. And then the lumbar segment, we have the medial group that are supplying the lower limb muscles. And then we have the central group that are forming the lumbosacral nerve. Now, the sacral group, the medial group of them would supply the lower limb and the perineal muscle. Honestly, there isn't much to explain in these two, and you just have to memorize them. They will make more sense to you if you link them to the pictures of the segments of the spinal cord, and you'd see in the cervical segment has very big anterior gray horn cells. That's why it has 3 groups and so on. But it's mainly memorization. There isn't much to explain, and this is just a table where you can see everything together, okay? Now, after discussing the gray matter, we're going to move to the white matter. And the white matter is basically composed of the spinal cord columns or the tracts. Whenever we say the word tract or column, it's a collection of axons that is present in the central nervous system. And it's white again because it has the myelin sheath. So when it comes to the tracts, we have ascending tracts and we have descending tracts, okay? We're going to start talking about the ascending tracts. So now we actually start the spinal cord lecture. After the ascending tract, we're going to have a 10 minutes break. But for now, I want you to give me your full attention because we're going to start with the bulk of the lecture. Okay? Yalla bismillah. Okay. So when it comes to the ascending tract, first, let's look at the anatomy of the spinal cord. We know this is the gray matter and this is the white matter. And we said the tracts or the columns are only present at the white matter. Okay? When it comes to the tracts, first we're going to start talking about the posterior white column, this one. And the posterior white column only has sensory tracts. There are no motor tracts, so it only has ascending tracts. Now, these ascending tracts, there is a portion of it that is called fasciculus gracilis, and the other one is called fasciculus cuneatus. I'm going to explain them further. I'm just trying to visualize everything together. And then if we look at the lateral white column, we have the spinocerebellar pathway. As the name indicates, spinocerebellum, cerebellum, so it's going from the spinal cord to the cerebellum. We have the posterior spinocerebellar tract and the anterior spinocerebellar tract. All of them are present in the lateral white column. And then we have the anterior lateral pathway. We have the anterior spinothalamic tract is present in the anterior white column, and the lateral spinothalamic tract that is present in the lateral white column. Collectively, we refer to them as the anterior lateral pathway. If this seemed like a lot of words, it's so normal. We're going to explain them and simplify them now, okay? So we're going to start with the dorsal column, which is this one. And now, as I mentioned, the dorsal column has only sensory tracts. Now, there's fasciculus gracilis and fasciculus cuneatus. These two tracts are very important when it comes to touch discrimination, vibration, and conscious proprioception. Remember when we talked about telling the difference between 2 points and then feeling the vibration and consciously knowing that your thumb is up and thumb is down? The tracts that are responsible for this information would be the fasciculus gracilis from the lower limb and fasciculus cuneatus from the upper limb, okay? And this explains to you why fasciculus gracilis is kind of more medial than fasciculus cuneatus, because it's an ascending tract, it's going upward. So imagine if this is the spinal cord, okay? And then you have a tract that is going upward from the lower limb, that's the fasciculus gracilis. It's going upward, and then when you reach the upper limb, the fasciculus cuneatus joins, which is this finger. So it's more lateral, because it's joining after. So this explains to you the orientation, which you must again memorize because questions come also in gracilis is medial and cuneatus is lateral. The way I remembered it when I was a second year is just fasciculus gracilis reminded me of the muscle gastrocnemius, which is the calf muscle. So it just remembered gracilis is for the lower limb and fasciculus cuneatus is for the upper limb. And the sensation that we feel are the two touch discrimination, vibration and conscious proprioception. Okay? That's for them now. Now we're just going to discuss the function and touch upon them briefly. Now the other one would be the anterolateral pathway. The anterolateral pathway is made from two tracts, the lateral spinothalamic tract and the anterior spinothalamic tract. The lateral spinothalamic tract, which is this one, is responsible for pain and temperature, and the anterior spinothalamic tract is responsible for crude touch and pressure. Now, crude touch is just the touch that is not very fine. Yani, you just, when you touch something and feel it, it's not a very fine touch. That's what I refer to as crude touch. Okay. And now the last one would be the spinocerebellar tract, which goes from the spinal cord to the cerebellum. It is responsible for unconscious proprioception. And if you think about it, the function of the cerebellum, yani, as you probably know from high school, and know it's to coordinate your movement. So it makes sense that it goes to the cerebellum to provide information about your unconscious proprioception. Because when you're moving, you want to be unconsciously aware of the position of your joints, of your muscles, so that your movement is well coordinated and you move smoothly, basically. So that's for the spinocerebellar tract. Now we're going to move into details. So we're going to start with the dorsal column. Bismillah. Okay. Now, very basic concepts that we must understand about all of the ascending tracts is there is always three order neurons. We have the first order neuron, and in all of them, it is the dorsal root ganglion, the pseudounipolar neurons that are present in the dorsal root ganglion outside the spinal cord. This is the first order neuron in all of them. So you shouldn't struggle thinking, what's the first order neuron ever? They're always in the dorsal root ganglion. Now, the second order neuron are either present in the posterior gray horn of the spinal cord, because this is where remember we said the posterior gray horn are the sensory columns are present. So it makes sense to us because ascending tracts are all sensory. So it makes sense that the second order neurons be present in the posterior group, or they can be present at the level of the medulla. Or you can see examples of that. A medulla is one of the components of your brainstem. So you have the pons, medulla, and medulla, pons, midbrain. So the nuclei are very commonly present in the medulla. You're going to see this in the brainstem lecture as well. But yeah, the second order neurons of the ascending tracts can also be present in the medulla. And then we have the third order neurons. They're usually present in the ventroposterior lateral nucleus of the thalamus. We're going to see it now, okay? So now let's start with these pictures. Okay, your phone is the first one. Your phone is vibrating in your pocket. Or you guys, you're supposed to see this as a needle, but it suddenly looks like marshmallows. But anyway, so these are two needles. So this should remind you of the fine touch that I talked about, two touch discrimination. When someone touches you and you can tell, these are two pens that are touching me. And then this is the conscious proprioception. You're consciously aware and you're sitting here, okay? Now let's say someone, مثلا, pricked you with these two very closely placed needles, or you've touched your phone that is vibrating. Now you're going to have your pseudounipolar neurons. The peripheral processes would take this sensation, and then the central processes would transmit the sensation to the spinal cord. Okay? Now let's move to the spinal cord and let's see what's happening at the level of the spinal cord. So the first thing that's happening, sorry, let me just move this. Okay. So we're here. We ended here. We had the first order neuron, which is the dorsal root ganglion. We had the pseudounipolar neuron. It's taking the sensation from your hands, from your lower limb, from any parts of your body, and it's transmitting it to the spinal cord. Now, when it comes to this, to the lower limb, we said it's going to be fasciculus gracilis. So if it's coming from your lower body, the information is going to go through fasciculus gracilis. Then you move to your upper body. The green line is your fasciculus cuneatus. Okay. So it's going to be taken by fasciculus cuneatus, and again, gracilis is more medial than cuneatus. This is at the level of the spinal cord. So up until now, nothing has moved. Everything's just ascending the way it has entered. We took the information and we're going upward. Then we're going to move to the medulla. Let me just take my pen. Okay. Now, when we've reached to the medulla, what's going to happen is these fibers that just ascended would cross the midline and move to the contralateral side. Okay, so they were initially here. Now they would cross the midline and they would kind of switch. But before they do that, they're going to synapse with the second order neurons. So what's the second order neurons? Remember, we just said the second order neurons can be present in the medulla. here, the names of the second-order neurons are so easy. They're very similar to fasciculus gracilis and cuneatus. Once you think fasciculus gracilis, know that the second-order neurons is a nucleus gracilis. And fasciculus cuneatus, the second-order neuron would be fasciculus cuneatus. After they synapse, they're going to cross the midline. And then they would ascend as the medial lemniscus. Let's throw it together so that it makes more sense. So I'm just going to start from the spinal cord so it makes more sense to you. Okay, let's throw the spinal cord first. Okay, this is our spinal cord. Okay. And we had, excuse the drawing, I just want to make sense of it because it's very difficult to view it here, the crossing over. First, we're going to have the fasciculus gracilis that is coming from this side, and then we have another fasciculus gracilis that can come from this side as well, okay? And then we had fasciculus cuneatus that is coming from this side, from the upper limb, and then fasciculus cuneatus that is coming from this side. Now they reach the medulla, and in the medulla, we said they're going to find their second-order neurons. When it comes to fasciculus gracilis, the second-order neuron, this in blue, is the nucleus gracilis. And when it comes to fasciculus cuneatus, the second-order neuron in purple is the nucleus cuneatus, okay? Now they're going to synapse with their second-order neurons. وخلص, the first-order neurons are done. So they've synapsed. Now what happens is the first-order neuron is going to cross, the second-order neuron is going to cross to the contralateral side for both fasciculus gracilis and fasciculus cuneatus. And the same goes for the opposite side. So what was on the right is now on the left and vice versa. As they're crossing over, they're going to form these fibers that are kind of like an X because they're crossing over. These fibers is what we refer to as the internal arcuate fiber, okay? So whenever we say the internal arcuate fibers are these fibers just at the point of crossing. After they cross and they form the internal arcuate fibers, they would continue as one very thick structure or one very thick tract that is going upward. And this thick tract is what we call the medial lemniscus, okay? So we had fasciculus gracilis, carrying two-touch discrimination, vibration, and conscious proprioception from your lower limb. And then we had fasciculus cuneatus, carrying the same from your upper limbs. They ascend ipsilaterally at the level of the spinal cord. So at the spinal cord, there is no crossing over, they don't move. And as they're ascending, they reach the medulla. In the medulla, they're going to synapse with their second-order neurons, which are nucleus gracilis and nucleus cuneatus. After they synapse, they're going to cross to the contralateral side. When they're crossing, they're going to form these internal arcuate fibers. Then they're going to ascend, forming the medial lemniscal tract, which is ascending on the contralateral side. Let's view it here. So they started, for example, on the left side. This is the left side. And then it ascends ipsilaterally at the level of the spinal cord. It's going to synapse, crosses over, and then ascends as the medial lemniscus all the way up until it reaches the thalamus. When it reaches to the thalamus, it's going to synapse with the third-order neurons that are present in the ventroposterior lateral nucleus of the thalamus. A nucleus, again, collection of neuronal cell bodies. So there are neurons that are present in the ventroposterior lateral nucleus of the thalamus. They synapse there. And then this nucleus, the third-order neurons, would transmit the signals to the post-central gyrus or the primary somatosensory cortex. And this is the dorsal column. This is how it works. It's honestly a very easy, one of the easiest tracks to study once you understand the concept. So again, we have the purple fasciculus gracilis coming from the lower limb. Then you add cuneatus, which is the blue ipsilateral at the level of the spinal cord. Then they synapse with their second-order neuron. They cross the midline, forming internal arcuate fibers. Then they ascend as the medial lemniscus. They synapse with the third-order neurons at the ventroposterior lateral nucleus of the thalamus. Then they transmit the signals to the post-central gyrus. And that's for the dorsal column mainly. This is just words of what I just said. Now, if there is a lesion of the dorsal column, we have two possibilities. A lesion could either be present at the level of the spinal cord, or it can be above the spinal cord at the level of the medulla or above. Now, when it's at the level of the spinal cord, the lesion would be on the ipsilateral side. When I say ipsilateral, it means on the same side. When I say contralateral, it means on the opposite side, okay? So if there is a lesion on the spinal cord level, it's going to be on the ipsilateral side because the fibers, as we just saw, they didn't cross yet. This is the spinal cord. They're still ascending on the ipsilateral or the same side. They didn't cross, they didn't move. So a lesion there would cause ipsilateral loss of their function, two-touch discrimination, vibration, and conscious proprioception. Why? Because if you interrupt this segment here, everything below wouldn't be able to transmit the signals because you need all of them to transmit the signal upward. So if there is a lesion here, anything below this lesion would stop functioning. You wouldn't be able to feel the vibration, two-touch discrimination, and conscious proprioception. However, if there is a problem at the medial lemniscal level, which is above the spinal cord, so let's just take a look at the medial lemniscus. Okay, here it is. Now the medial lemniscus is this structure. it is formed after they have crossed over, right? So because it has been formed after the crossing over, it's going to cause a contralateral lesion. Yani it's going to represent the opposite half side of the body because the crossing over has happened after the spinal cord. So if there is a lesion at the level of the medial lemniscus, the person would lose all the opposite half side of the body to touch discrimination, vibration, and conscious proprioception, because of the lesion at the level of the medial lemniscus, all the sensation from this half of the body wouldn't be able to transmit the signals to the brain, okay? So these are the major function and lesions that are present in the dorsal column. Does anyone have a question about the dorsal column? What's the level of the medulla? The medulla is, the medulla is the brainstem. So it's like at the base of your brain. It's above the spinal cord. So you have the brain, and then you have a brainstem, and then here you'd have the spinal cord, okay? So anything above the spinal cord would basically be at the level of the brainstem and the brain. So the medulla is one of the components of the brainstem. You have the medulla, the pons, and the midbrain. Got it? Okay, tamam. So whenever I say medulla, because I'm going to be referring to it very frequently, I'm referring to the brainstem. Tamam. طب is this concept cool? Where did they go at last? They will go to the post-central gyrus. Okay. So in your brain, you have different gyri and sulci. You don't need to know this now. You're going to take a full lecture about the cortex. So every segment of your brain kind of interprets certain information. The precentral gyrus is responsible for the motor information, and the postcentral gyrus is mainly responsible for the sensory information. So most of your ascending tracts will transmit the signals to the postcentral gyrus, which is the sensory gyrus or the somatosensory cortex. And this is where the sensory information are kind of interpreted. This is not something you should know at this point. You should just memorize it. But I'm just explaining it so you understand it. You're going to take a full lecture on the cortex and a function of every single gyri and sulci that are present in the cortex. But for now, just know postcentral gyrus is sensory. Okay? Does that make sense? That's tamam. Okay, is everything clear so far about the dorsal column? Before we move to the next tract, to avoid confusion, it's better to ask now. Clear? Okay. Now we're going to move to the other tract. So we have a person who's suffering from pain. They have injured their knee and they have pain. And then there's fire, which shows us temperature. And then, you know, when they're measuring your blood pressure, they apply so much pressure with this structure. So this should represent pressure. And this should represent the crude touch. Honestly, I couldn't find a picture that's so representative of crude touch. Just understand that this one should represent crude touch. Now, whenever you're feeling any of these, or if you touch the fire with your hand, these signals would be taken by your pseudounipolar neuron that are present at the dorsal root ganglion. The peripheral processes would take these signals, and then the central process would take them to the spinal cord. Now, at the spinal cord, let's see what's happening in terms of pain, temperature, crude touch, and pressure. When it comes to interpreting these sensations, we have a tract that is called the spinothalamic tract, okay? So we've ended here where the first order neurons are present at the dorsal root ganglia. We said the central processes are coming and they're taking the information into the spinal cord. What happens is once this dorsal root ganglia enters the spinal cord, which are the first order neuron, they will immediately synapse with their second order neuron, which is the substantia gelatinosa. Remember substantia gelatinosa that we discussed in the gray matter? Let me just go back so you remember it. Okay, this was our substantia gelatinosa. And we said that it's responsible for pain, temperature, crude touch, and pressure. This is actually the second order neuron of the spinothalamic tract. Okay? So the dorsal root ganglion, which is the first order neuron, enters the spinal cord, synapses with substantia gelatinosa, and after it synapses at the level of the spinal cord, it crosses over to the contralateral side. So it enters, synapses, then it crosses over. And when it comes to the spinothalamic tract, we have the anterior spinothalamic tract and the lateral spinothalamic tract. This picture only shows the lateral spinothalamic tract, but it's very similar to the anterior. I'm going to explain the anterior later. So it enters, synapses with substantia gelatinosa, crosses to the contralateral side, and because this is the lateral spinothalamic tract, it will ascend at the lateral white column. So it ascends all the way in the lateral white column and then it reaches all the way until the ventroposterior lateral nucleus of the thalamus, where we have the third order neurons. So the second order neurons would synapse with the third order neurons. And then the third order neurons would take the signals again to the postcentral gyrus, because we said the postcentral gyrus is the gyrus that is responsible for the sensation, okay? Or the primary somatosensory cortex. It has two names, either postcentral gyrus or primary somatosensory cortex. So again, just like we said, this is the worst for it, but I want to show you the anterior spinothalamic tract. The anterior spinothalamic tract would come, enter the spinal cord, synapse with substantia gelatinosa, which is here, the second order neuron. After it synapses, again, it crosses the midline, but it ascends in the anterior white column. Now, after it ascends with the anterior white column, something that's not really shown in this picture is that these two tracts would join together and they would form a structure that is known as the spinal lemniscus, okay? Remember when we talked about the medial lemniscus and the dorsal column? This is a very similar concept, but instead of forming, okay, here, it's shown here. Instead of forming the medial lemniscus, which was in case of the dorsal column, they're going to form the spinal lemniscus, which is shown in the blue color here. And then if you look at the yellow color, it's showing the medial lemniscus, which was in the dorsal column. And if you notice, another thing to notice is that the spinal lemniscus is more lateral than the medial lemniscus. So as the dorsal column is ascending, the medial lemniscus ascends medially, and the spinal lemniscus ascends laterally. Okay. So someone's asking me to repeat, so I'll repeat so you understand it more. Okay. We're going to explain I'm actually going to draw it. I think it's better if we draw it. Let's take this as a template to draw. So this is the spinal cord, okay? Let's just draw the spinal cord, okay? And we had the first order neuron, which is our dorsal root ganglion. It enters the spinal cord. This is the first order neuron, okay? I'm just going to color code the first order neuron as red. And the first order neuron is going to synapse with our second order neuron, which was substantia gelatinosa, which is represented in blue here. This is our substantia gelatinosa. After it synapses with substantia gelatinosa, the second order neuron would cross the midline. Now we're going to discuss the lateral spinothalamic. We're not going to talk about the anterior, just the lateral. The second order neuron would cross the midline. It's going to go to the lateral white column, okay? Across the midline at the level of the spinal cord. After it crosses the midline, it's going to ascend all the way up until it reaches the brain. You know, we know the third order neuron, ventroposterior lateral nucleus of the thalamus, and then both central gyrus. Okay, is that clear until now? Before I continue. Yes, okay, tamam. Now the second order neuron, the anterior spinothalamic tract has a very similar concept. It has the same first order neuron, which is the dorsal root ganglion, but for the sake of understanding, I'll just color code the first order neuron in green when it comes to the anterior spinothalamic tract. Now we have the dorsal root ganglion, pseudounipolar neurons, they enter the spinal cord. Now again, it will synapse with substantia gelatinosa, okay? This is the substantia gelatinosa, which is the second order neurons. After it synapses, it will go to the anterior white column on the contralateral side. So it crosses to the contralateral side. After it crosses, it will ascend too, just very similar to lateral spinothalamic tract. Up until now, there is nothing that's different. But what's special here is that the lateral spinothalamic tract, which is this one, and the anterior spinothalamic tract, which is this one, they will join together. And when they join together, as they're ascending, they're going to form a structure, the structure here, okay? And this structure is called the spinal lemniscus. So if we go backward to this picture, that will show it clearly. The yellow one is the medial lemniscus that we discussed in the dorsal column. Remember? It was this one, the structure here. Where is it? Okay. This was our medial lemniscus at the dorsal column. But the spinal lemniscus is what we see in the spinothalamic tract, which is represented in blue in this image. Okay, you got it? That's perfect, alhamdulillah. Okay. Now, this spinal lemniscus ascends all the way up under the ventroposterior lateral nucleus of the thalamus, and then the third order neurons would transmit the signals to the postcentral gyrus or the primary somatosensory cortex. I hope this made sense. Did everyone understand this point? I know it's a bit confusing. I can repeat if anyone didn't. Understood? Clear? Okay, tamam. Perfect. So this is for the spinothalamic tract. Okay. 1 sec. Tamam. Again, now another thing to remember is the lateral spinothalamic tract is responsible for pain and temperature, okay? So we said, this whole substantia gelatinosa is responsible for pain, temperature, crude touch, and pressure. But the lateral spinothalamic tract is for pain and temperature, and the anterior spinothalamic tract is for crude touch and pressure. That's another thing to remember. Now we're going to talk about the lesions that can be present at the level of the spinothalamic tract. If there is a damage to the lateral spinothalamic tract, this will cause contralateral loss of pain and temperature at the level of the lesion. Why is it contralateral? Because as soon as the first order neuron enters and it synapses with the second order neuron, it immediately crosses the midline. So any lesion, when it comes to pain and temperature, just remember it as any lesion is going to be on the contralateral side because it immediately crosses the midline as soon as it enters the spinal cord. So whenever you see loss of pain and temperature, know that the lesion is on the contralateral side. And the pain and temperature has been lost on the opposite side because as soon as these first order neuron synapses with the second order neuron, the second order neuron crosses the midline. Is that clear so far? Before I move to the third one. If there is something that you don't understand, I can repeat. Okay, tamam. Okay. Forget the drawing that I just did. Just focus on that. Okay, let me just remove it. Okay. Now there's someone who's walking, and we just said, and while you're walking, you need to know where your muscles are, where your joints are. This person is not actively thinking, okay, my knee is going up, my knee is going down. No, it's just unconsciously your body knows, and your knee just went up, your knee just went down, you just contracted this muscle, and so on. You unconsciously know this, and that's what we refer to as unconscious proprioception. This unconscious proprioception is going to be taken by this first order pseudounipolar neuron at the dorsal root ganglion. And as it takes the signal, it's going to enter the spinal cord. Now let's see what happens at the level of the spinal cord. This signal is going to be transmitted through the posterior spinocerebellar pathway. And this should make sense to you because we already discussed the function of the cerebellum. It's the coordination of your movement and to make your move, and you move very smoothly. And it makes sense, in order for the cerebellum to maintain this very coordinated movement, to know also where your position, where the position of your limbs are, where your hands are, where your bones, muscles, ligaments are. So in order for the cerebellum to know this information, subhanAllah, we have this posterior and anterior spinocerebellar pathway. We're going to start with the posterior spinocerebellar pathway, which is very easy and very simple. So we're going to have the first order neuron, which is the pseudounipolar neuron that we just discussed, this one here. It's going to enter the spinal cord. Now, as it enters the spinal cord, it's going to synapse immediately with the second order neuron that is present in the posterior gray horn of the spinal cord. And this second order neuron is known as Clark's column that we discussed. But can someone remind me, where did we say Clark's column starts and where does it end? Because it's not present throughout the whole length of the spinal cord. It had specific segments of the spinal cord where it's present. Yes, C8 to L3 to L4, yes. All of you answered it correctly, yes. So this Clark's column is actually the second order neuron of the spinocerebellar pathway. So the first order neuron enters, immediately synapses with the second order neuron, and in case of the posterior spinocerebellar tract, it will ascend on the ipsilateral side. It ascends all the way, and instead of going to the ventroposterior lateral nucleus, and that, the one we saw in dorsal column is spinothalamic tract, it will go to the cerebellum, because the name says spinocerebellar, so from the spinal cord to the cerebellum. And it enters the cerebellum through the inferior cerebellar peduncle. Now, in the cerebellum, we have three peduncles. We have inferior cerebellar peduncle, middle cerebellar peduncle, and superior cerebellar peduncle. When it comes to the posterior spinocerebellar tract, it will enter the cerebellum through the inferior cerebellar peduncle. That's all you need to know for now. You will talk about this later when you take the cerebellum. But until now, just keep in mind, an posterior spinocerebellar tract enters the cerebellum through the inferior cerebellar peduncle. And this is how our cerebellum knows the position of our joints, our muscles, and so on, because we have unconscious proprioception. We don't know that we know that our muscles are at this position right now, okay? This is how the cerebellum coordinates our movements. So that's for the posterior spinocerebellar pathway. It's very easy. Now we're going to talk about the anterior spinocerebellar pathway, which is a bit more complicated. It's not really complicated. It just does this very weird thing where the first order neuron enters just the same way, and then it's going to synapse with Clark's nucleus, which is the second order neuron of the spinocerebellar pathway. Up until now, tamam adi, everything's normal. But what it does is, it's going to cross the midline and it's going to go to the contralateral side, okay? This is how it starts. So it crosses the midline, only the anterior. After it crosses the midline, it's gonna ascend, 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 up until it reaches the level of the cerebellum. Now, when it reaches this, the level of the cerebellum, or at the level of the brainstem, this anterior spinocerebellar pathway decides, okay, I'm gonna cross the midline again, and it crosses the midline, and instead of, like, we have two cerebellum, okay, we have one on the left and one on the right, and instead of going to this one that's on the same side, it crosses the midline again and goes to the cerebellum on the contralateral side, and it enters the cerebellum through the superior cerebellar peduncle. Okay, I know it can be a bit confusing, but yes, they don't ask about details. No, they don't. But they sometimes, in the final, they suddenly just get one very low yield question. So if you want to get them right, I decided just to explain them for the sake of completion. But yes, they generally in exams don't go in details as much as I'm explaining right now, especially in spinocerebellar tract. Because you're going to talk about this tract in more details, or the cerebellum, when you take the cerebellum lecture. And it's going to make more sense to you أصلا by then. But I wanted to explain it in case someone wants to like have the full understanding of the lecture. Of course. Okay. But the information that you must remember is that the second order neurons of the spinocerebellar tract are present in the Clark's nucleus. And the one, if they ask you, which one, oh, yes, there was a question. I saw it in previous batches. They asked, which of the following tracts cross the midline. Okay. So this is something to keep in mind, knowing which tracts cross the midline and which don't. And the anterior spinocerebellar tract would be one of the tracts that do cross the midline, but the posterior doesn't, okay? So that's all you need to know, I think, for now. Because eventually, it crosses the midline twice, like it crosses once and then again crosses, so eventually it's kind of ipsilateral, but just know that it crosses the midline. And one information that would help you when you're studying the lecture of the cerebellum is that the anterior spinocerebellar tract enters through the superior cerebellar peduncle, and the posterior spinocerebellar tract enters through the inferior cerebellar peduncle. I think if you know these, you're good to go, inshallah. Yani. Just know anterior spinocerebellar and it crosses the midline because they sometimes ask. Okay, that's it. For the accessory sensory tracts, honestly, I haven't seen a question about them. And he briefly touched upon them. They're not really important. I just added them in case any of you wants to study them. However, you're gonna touch upon them again in the brainstem in a bit more details. So just know that the spinotactile is for visual reflexes, the spinoreticulaire for consciousness, spinoalveolar for unconscious perception. He just mentioned that, so I'm not gonna explain them. You'll take them in a bit more details, not that much details, in the brainstem lecture, okay? So now we have the first question. Take your time answering it. Okay, all of you have answered A, and it's the correct answer. Substantia gelatinosa is responsible for pain and temperature. And remember, it is the one that is involved in the spinothalamic tract, okay? I'm honestly not adding as much questions right now at the ascending and descending tracts because I'm going to test your knowledge on them at the spinal cord lesions lecture.